This is an inaugural event that is being launched this evening. We are calling it Health Equity in Action. And so it is not lost on us that we need action to really drive health equity. And we cannot do this alone. And so although I am here before you at the top of this meeting, but know that there are many who have poured into getting this off the ground. And so I want to thank our partners at SUNY Downstate Medical Center, Arthur Ashe, for the Institute for Urban Health, for your collaboration and partnership in making sure that this happens. Also want to thank our sponsors for this event, both the New York Health Foundation and Health First. Thank you as well for your partnership. But yes, please give it up for all of those organizations. What I will say, and just leave you, that we know that in order to achieve the outcomes that we need, to make the changes that we need, we have to do it together. There is a lot of power in this room. There's a lot of power for those who have connected live stream with us virtually, but we know that we need you. And so we're asking you to lean in not only tonight, but beyond this night. And so what we're asking for this night and beyond is to think about how we can continue to cultivate a space that we're sharing ideas, that we're engaging in dialogue, but then we are inspiring action, collective action, that is. And so with that, because we are behind time, I'm going to ask Jeffany O'Garo to come up and kick us off by providing a land statement.
Good afternoon, everyone. Again, my name is Jeffany O'Garo, and I work alongside Dr. Torian Easterling in the Office of Community Health and Health Equity. We acknowledge that we are on the traditional, ancestral, unceded territory of the Lenape people. We recognize the resilience and persistence of the indigenous communities and their role in educating all of us about justice, equity, and the stewardship of the land throughout the generations. We acknowledge the place we are standing on as a sacred territory that was recognized as a free African American community, the second largest in the pre-Civil War era. The settlement was named after James Weeks, a stevedore who was born into slavery and gained his freedom, acquiring property along with other African American investors to build a self-sufficient town. We are reminded to reflect on the complex history of this land as we contemplate our way forward. Let us consider our role in reconciliation and actively contributing to building a community guided by principles of respect, collaboration, and justice. May this acknowledgement serve as a reminder of the responsibilities we have to the land and to one another. Let us thrive for a future where the stories of all who have shaped this place are honored and celebrated. Thank you.
Great. We chose this place specifically because of its history, and really important that we wanted to just pay homage to the land and those who have come before us and the work that they have done, because that's the collective action I'm talking about, that we know that there are winds beneath ourselves that are also pushing us forward. So with that, the next person that you will hear from probably needs no introduction for many of you in this room, but I will delay just a bit longer to just acknowledge Ms. LaRay Brown, the CEO of One Brooklyn Health, who was appointed in this role in July of 2017. And I think what's important for me to say that someone who has inspired me as a leader, in the healthcare ecosystem of East and Central Brooklyn, but across this state. Someone who is not only a leader, but a transformer, and bold and courageous and innovative in their strategies and thinking. And so with that, without further ado, I want to ask Ms. Brown to provide a welcome for this evening.
I don't know why I'm standing behind the podium. I don't have anything to look at. Thank you all for coming out on this cold evening, and for those of you who are streaming in, thank you all for committing your time. You know, I was hearing what Torian said, and I was looking at the screen where it says Health Equity in Action, and I, frankly, in talking to Russell, actually, as we were eating our vegetarian meal, which was, by the way, very good, we were talking about you know, work over the years, and while health equity seems to be the newest thing, it really is about social justice. It really is about partnerships. It really is about don't plan for me without me. It really is about engagement, and particularly engagement of the people who we have the privilege of serving. Engaging with those who we have the privilege of serving. And privilege to me is an extremely important word, because it also comes with the responsibility of being, frankly, of being respectful, being inclusive, and taking action as we hear from those with whom we want to work and with whom we are partnering to improve the lives of people, to improve the lives of the people who live in Brooklyn, and to improve the lives of those who live in New York City and in the rest of the state. And so what I'm hoping that we will engage in this evening is that collective discourse that can move us toward action, and more importantly, action that is not just checking off on a box, right, Russell? You know, we had this forum, check. We had these guests, check. But making a commitment for ongoing engagement, ongoing partnership, ongoing work, and ongoing holding ourselves accountable to achieving what we espouse as our aims and, frankly, our principles and our values. So with that, I'll shut up, because I'm so excited to hear what the speakers, what the panelists have to say this evening, and importantly, to hear the folks who are not only in the room, but who are listening to us in terms of what they see as important in the road that we are going to take and that we will take together. So thank you all very, very much.
Thank you, thank you. We also had some other invited guests, and unfortunately were unable to make the connection happen. So I do want to acknowledge that Assemblymember Stephanie Zinnerman, who is traveling right now, is online, but we're unable to sort of make the technical link. So I do want to acknowledge that Assemblymember Stephanie Zinnerman, who is Assembly Member of the 56 AD Assembly District here in Brooklyn, has joined us virtually. So we thank her and look forward to her partnership in this collaboration as well. All right, so we're gonna move along and start with our first presentation for this evening. And I want to call up another friend and partner, Dr. Kishor Malavade, to come up and provide some brief remarks, particularly on as we are thinking about aligning the work that we're doing with city and state advocacy, and more so specifically the upcoming Medicaid waiver and how we are going to be leveraging those resources for this work. And it's certainly it is not the only thing that we are looking forward to receiving as we think about resources. We know that we have a number of different levers in our policy, in data, but we also know finances are really important as well, but also the partnership, and that's where we sort of see the power of really achieving collective impact. And so I'll just quickly say that Kishor serves as the Executive Director and Medical Director for the Community Care of Brooklyn IPA, as well as the Vice Chair for the Department of Population Health at Maimonides Health. Kishor.
I will follow LaRay's lead and not stand behind a podium when I don't have any slides to show you. Thanks everyone for being here. And I just want to start with a story that takes me back about almost 20 years. I'm a psychiatrist, an emergency psychiatrist, a forensic psychiatrist, thinking about equity at the Bellevue Psychiatric Emergency Service, and a forensic psychiatrist seeing individuals who are coming from Rikers Island for evaluations at Bellevue. We had a very, very inequitable process for evaluating prisoners coming from the Department of Corrections versus civilians who are coming in through the emergency room. For several years, I was advocating for changing that and trying to create a more equitable system for those prisoners. I was only able to get someone to listen when I finally met LaRay Brown, who at Central Office really took the issue and helped move it along. And I think to the point of many of us here, it is collective action. You know, you can have ideas, but we really have to work together on these things. We have to communicate together, coordinate our efforts. Doing things like that really made a difference for providing more humane evaluations for everyone who needed emergency psychiatric help at the time. So thank you, LaRay, for that, and I will never forget that. I know, and I remind you of it every time I see you. The new waiver, how will it impact us? And I think I'm going to start with the waiver the way I started talking about the prior waiver, which was when I went around to a lot of practices and community organizations in Brooklyn back in 2014-15 as the waiver was coming, and they said, you know, well, tell us about what's coming. And I said, you know, I don't really know what's coming, so I'm not going to speculate about things that we don't know right now. We're still waiting. Our fingers are crossed that I'm speaking about the waiver and not someone from DOH today, because maybe they can't talk about it at this moment, and I'm hoping that means it's going to be out soon. But the waiver is focused on, and then I'll just step back as well to history, right? And I think it's useful as we think about what's going to come forward, how we got here, and certainly some of the mistakes, some of the missteps, some of the inadequacies of efforts to try to transform the public health system in New York and around this country. So I was involved in the district waiver as part of Community Care of Brooklyn. I spent a lot of time working with many people in this room. It's good to see Gwen again. It's been a long time. And I think many here know we're very frustrated at how that waiver was rolled out. It didn't really do much to address health equity. There were some efforts and nods around that, but fundamentally it was about checking boxes, transactional efforts, if you wanted it to be that way. You could earn money in a system if you did the things that were needed to be done. What we recognized in Brooklyn, and it was with many people here and many more that aren't here right now and hopefully are live streaming, we had to think more organically about how are we working together. It was clearly going to involve communities to, and I'm coming from a hospital. I've been a hospital doc most of my career, but when you're in the hospital, you realize, and certainly in an emergency room, you realize things aren't working out in the community. People are coming in because the community, things are failing. The healthcare system is failing them. Physicians, everyone, things are falling apart. And certainly in psychiatry for me, much of our efforts is just watching someone's social life totally fragmented and falling apart. Their opportunities in terms of economic well-being are just non-existent. and seeing how somebody's life can be fractured. For me, it was important to get out into the community and start thinking about what can we do differently and collectively. And so I was at Maimonides, I was working as part of Community Care Brooklyn as we were forming it, and I remember thinking about our efforts and seeing all these tests that we had to do, and we really said, no, we don't want people to think about the tests and how we earn dollars by checking off these boxes. We have to start thinking about what are the needs to address, a broken primary care system. And in Brooklyn, what we know is it's a fragmented system. That doesn't have to be a bad thing necessarily. You can work with that. There are different partners. There were small practices, FQHCs, hospital clinics. All of us were working with many of the same individuals and communities, but we needed to work together. And it wasn't about, having, just everyone in one system. That never will work out here, and that's fine. But because we have a lot of power and strength in the communities that are already there, and we're just not tapping into that. That I could see from, and we could see that from the hospital side. So as we started building that network, we really did think about, what are the needs to really get hospitals working closer with the community, and certainly small practices, and we really were intentional about doing that. My former CEO at the time, Pam Breyer, used to say, I remember the first time her sitting in the boardroom at Maimonides, and she wasn't sitting at the head of the table because she wasn't leading that meeting. She was one of many people in that meeting, and we really felt it was important to get voices out there, listen, learn, and come up with ideas together about how we were going to solve some of the problems. And I think most importantly, when I look back also, it was striking to me, for many of us, I'm looking at Sherry now, how there were people, there were so many things going on, and we had no idea what was going on, right? It was like, there are things happening in East New York, there are things happening in Canarsie. We're not coordinated in any way. We need to kind of know what's happening out there. We need to kind of connect with that. And I fast forward now 7, 8 years, and it's like, okay, there's real relationships and trust that have been built over that time. And I think we're at a moment where we can do a lot of really great work to advance health equity in New York and in Brooklyn in particular. We can't solve the problems of the entire city and the state, but we know that we've got a lot of strong partners in Brooklyn. It's so much of it is about how so much is happening at the community level in terms of social care. And so the new waiver really is going to be addressing health disparities and advancing equity by focusing on social care. Social care is important, but I will say the caution right now is I'm hearing people talking about it as, again, transactional relationships, and we're going to pay community organizations. And the paying, of course, funding that system is important, but supporting the infrastructure of social care is going to be far more important. How do we really work together to create a coordinated, really integrated delivery system that's about health and social care that doesn't recognize the difference? As a psychiatrist, it's not mental health and health, it's health. And it's all about, these are all part of the same thing that we need to be thinking about together. So the waiver should be helping to draw funds into New York and to places like Brooklyn to really support those efforts. But it's going to be about the work that we do on the ground. We can help, and I think we've done a lot to help with some of the administrative infrastructure to support those efforts, but we'll see what the details are. The details are, it's still going to go flowing through managed care companies. I've got some concerns about that, as we all, my friends at Health First, of course, and I love Susan Bean and the team, but I don't know, if that's the right way dollars should flow here, but it's okay. We'll work together. We'll figure it out. But really, we need to get the funds into the community. We have a lot of work that we've been doing that's very upstream from healthcare, and that's important work around health and wealth, and many of you here have been working on those efforts. We won't change, healthcare will not solve our problems. Better healthcare will solve many problems, but we need to do more beyond healthcare and beyond just even, creating a much stronger social safety net, but economic opportunity in the borough. So I wish I could tell you a lot more about the specifics of the waiver. I don't have those details right now. Hopefully in a month, we'll be able to talk about some more significant details around that. But I want to thank you for your time, and I want to help move this agenda along and hear from our panelists. So thank you for your time.
Thanks so much, Kishor. I think, it's a couple things I'll just say, because as we heard about, one, the waiver, and we've been sort of thinking about how do you sort of organize ourselves, a lot of things that we've been hearing as well is we've been here before. And so some folks may have that same sentiment right now. Folks may on live stream who are tapped inversely may be saying that as well. And that is true. I think we've been in these meetings before. We've been having these discussions, talking about collaboration and partnership. And then when we talk about 2 years, 3 years out, when those investments have dried up, and then we end up going back into our corners. And so the question is, how are we thinking about this coordination, and how do we sustain it, right? And how do we sort of make sure that we're not really just hinging our partnership on investments, because those investments will come and they will stop and they may come again, and those ebbs and flow we expect. But we know that the death and dying in our community does not. And we always will have to keep our foot on the gas, making sure that we're protecting and improving the lives of residents in Central and East Brooklyn. And so therefore, the funding cannot be the driver. We have to sort of go back to, as King talks about love being the center of why we're fighting for justice. And I think that's what's really important. But the question is, how do we get there? And I certainly do not have the answers. But I am hoping that in the next discussion, we were going to lift up some of those strategies and those ideas to help inform the direction that we want to go in. And so with that, I want to call up Bruce Richard, Gretchen Susi, François Philippe to come up to the stage and join me on the panel. We're going to have a sort of a little appetizer before we go into our full panel, all right? To sort of describe your work and the things that you've been doing in this community, because a lot of people here in the room know who you are. Maybe you might not know them, but they know who you are. I'm looking at Bruce. So let's just go down. We'll start with you, Bruce. Just a bit about who you are and the work that you've been doing.
Well, I worked for many years with 1199 SEIU. I was a part of the leadership team as an executive vice president. And we were engaged in trying to keep a lot of hospitals open that closed. And in the course of that, we ended up establishing a number of coalitions. And finally, at some point, we got it right and pulled together the Interfaith Coalition, was able to keep Interfaith open. And that was the first time we succeeded in doing that. And so we continued on in the coalition work based on the recommendations that came out of that coalition. The governor adopted it. Vital Brooklyn took off from some of that, adopted some of that. And we worked together with DISRIP and was able to carve off out of that a Central Brooklyn hub, which became the Community Action and Advocacy Work Group. And a lot of conversation out of that came the East Brooklyn Call to Action, and just a number of different projects and programs. And so it was a big change for the union, because a lot of people think of the union as handling grievances and contracts. And so we really learned that the union needs to be playing a very partnership role with community and see itself more as a stakeholder. And so we're learning a lot about what that means. And so tonight is a continuation of a lot of that work and thinking. I'll stop there.
Thank you. Thank you. François?
Good evening, everybody. My name is François-Edy Philippe. Excuse me. And I'm formerly from the Training and Employment Fund of 1199 CIU. I just recently retired. However, retirement doesn't mean that I'm just taking off and sitting at home. I've been engaged with OBHS over the last 5 years, at least, yes. Even prior to OBHS, and I started collaborating with Torian and the team, and it's been impossible for me to walk away from that work because it is so fascinating. So prior to that, I worked at Malavade, where I was hired by Pam Breyer, incredible leader. And even before Malavade, I worked at the Hospital Albert Schweitzer in Haiti, where we have another alumni here in the back of the room. So I've been blessed to work with a bunch of incredible leaders. And it makes it possible for me to understand that the work that we're doing here, what we're proposing to you, this evening, is extremely important, but on a very personal level. When we're talking about these issues in Central and East Brooklyn, I guarantee you that every time that I meet, either a patient or a resident of Central or East Brooklyn, I meet one of my parents, siblings. They all look like my mothers, my sisters, my brothers, my cousins. So it is about my own survival. So I take it very personally. In my past, prior life, I had gotten a degree in civil engineering, and this kind of deformed my thinking in terms of, I see everything in terms of systems and structures. And this is what I hope I can contribute to. Thank you.
Great. Thank you. Dr. Susi?
Thank you, Dr. Easterling. Good evening, everyone. My name is Gretchen Susi. I am the Deputy Director at Brooklyn Communities Collaborative, and I have the great privilege and feel very blessed to be able to work with all of my colleagues here and in the audience. And I've been working with everyone here since 2018, which is when I came on board to help with I think it's not one word, but going back to your one word, I would say that participatory action research. That's my one word, and that's the thing that I've been working on with the team since 2018. And I have to say, I started working as a participatory action researcher when I was in graduate school at the City University of New York, where I worked with Phil Thompson. He was one of my early advisors. And I bring up Phil because Torian was also talking about, how do we sustain things over a long period of time? And I started working with Phil in 1995. And all of the things that that I worked on with him, I feel like in many ways, the ability to work here with all of you is part of that long trajectory, but with a single vision. And for those of you who don't know Phil Thompson, he was recently deputy mayor in the de Blasio administration, and he's now gone back to MIT, where he's in the Department of Urban Studies and Planning. But when he was here in New York, but before then, we worked on research on social capital and public housing, how residents could form alliances with the trade unions, the building trade unions, to get jobs for residents, and all of it was always based in participatory action research. So when Phil came to be deputy mayor, and I got back in touch with him just to say, oh, I'm so glad you're in New York and you're not in Boston right now, he said, "Hey, well, actually, what are you doing? Because we're working on all of this participatory action research, and now that I'm deputy mayor, I can't work on it as much anymore." And so there, there was a long trajectory of, more than 20 years of working on participatory action research with public housing residents, but on a pretty small scale. And now with this group, with the work of DISRIP, with all of the continuity of leadership, with the commitment of leadership to make these big research projects happen with high school students who were trained by undergraduates from Medgar, from Brooklyn College, from Kingsborough, and who were trained by graduate students from CUNY, from Pratt, some from MIT. There's just been this community of inquiry that's been created. That's a shout out to Roger Green, who couldn't be here with us tonight, but who is a big influence over all of the work that we've been doing. And so, so just to touch on some of these points of PAR and the work of PAR that just keeps expanding. So we keep doing more and more PAR. We try to make part of every aspect of the work that we're doing at Brooklyn Communities Collaborative, with OBH, with 1199, with all of the partners who make up the work. And I really see it, and I think all of us really see it, as an inside and an outside strategy. And it's an outside strategy because we're armed with data. We're armed with the data that we have from the health department, from all the other data sources we use, but we're also armed with real, very up-to-the-minute data from young people, from older people, from everyone in between, from people we stop on the street, people we call. Thousands and thousands of people have been reached by each of the PARs that have happened since 2016. And so I just wanted to make one other point about I forgot to say the inside strategy. What's the inside strategy? PAR is a super galvanizing and democratizing activity. We develop, what do we all care about? How are we going to frame this? How are we going to ask the right questions? How are we going to ask the questions in under 5 minutes or in 15 minutes or however much time we have with people? And the things that we learn about are what is most important: health and housing, jobs, making premature mortality, making sure that reversing premature mortality. And I just wanted to give two examples of things that have come from the PARs very directly that have happened just 2 weeks ago. So we learned from the survey research, from all of the interviews, from the interviews with the elected officials who represent all of the neighborhoods in Central and East Brooklyn, that there are so many people returning from prison who come back to East New York, to Brownsville, and they're not taken up in the way that they need to be taken up. And so we had some funding from the Affinity Foundation. And over the past year, Shari, Kishor, our whole team at BCC, and all around, Bed-Stuy Restoration too, were able to identify 20 former justice-involved men who were non-trained, who have a stipend to go through training, and who are now trained as community health workers. And there was a graduation for them, I want to say 2 weeks ago, 2 Thursdays ago. It was so incredibly, what's the best word for it? It was very, just to see the circle come around and knowing that we need to make bigger and bigger circles and include more and more people. But at the same time, it was just very, it was very satisfying to see that the action that we heard from the action that the community told us is needed was there. It was in this room, and knowing that these young men, not all of them are old, but that these men are not, that they're part of this, and especially that they were part of. It could have been a job training in construction. It could have been a job training in any number of things that would have been useful. But the fact that it was community health workers, overhearing the conversations, talking to some of the young men, that very perspective of community health worker was very distinct from their own experience and very impactful and very emotional for some of them. And I'll stop speaking there, but I just wanted to bring those. What's that?
Just 2 things.
2 things. Oh, the other one is health and housing. When we as East Brooklyn Call to Action in 2019, we said, okay, there are all of these PARs that have happened, and Bruce was a big part of this. We have to make sure that they don't just sit on the shelf. And so the East Brooklyn Call to Action formed to make sure that, especially the PAR 1 recommendations, the action part of action research really happened. And so the summer of 2019, we did a balloting initiative. We collected more than 2,000 ballots, and we asked people to rank what's most important to you. What we learned from the research was that we could narrow it down to basically health and housing, food and fitness, premature mortality, and workforce. And so we went out and we said, okay, what is the most important to you? Health and housing was really the top. And so we said, okay, well, what can we do? People also need jobs, and so we've been working on, we have had a cadre of 15 people who've been trained in property management and stewardship of a healthy built environment. And we want to keep building out that training and have a whole group of folks who know how the buildings work, who can be gainfully employed in this industry of housing. And also, it's, you know, that all this Vital Brooklyn housing has been spurred by all of the work that you all have been doing together, and we want to have people who are operating who have this outlook, this stewardship of a healthy built environment. And so those are just two things that have come from all the work that everybody's been doing together over the years. And thank you for listening to it, and I'm very glad to be here.
No, but these were really great examples that you all brought up. And so one of the things that we had asked all of our registrants, we asked them about what does democratizing health mean to them. And so I want to read two quotes. And so we'll probably just leave it here as far as just focusing our discussion. But I want to read two quotes for you, and then you share with me what more aligns with the direction and what we're thinking about, what we're talking about, sort of the model of how we want to organize ourselves, how we want to think about the principles and the foundations that we stand on, and then how we want to inform the direction. And so the first quote reads, this healthcare democratization is characterized by two major factors: the distribution of data and the ability to generate and apply insights at scale. It promises a world in which patients armed with data, technology, and access to expertise can take charge of their own well-being and manage their own health, right? And so the source of there is a Stanford Health report. And then the second is actually a National Academy of Medicine, where the quote reads, plugging the voice of community into the right kind of political power grid will do more to create health and wellness than any other single intervention. And so I wanted to get your reflection on both of those quotes. Here we're talking about the use of data. We know that's really important. And allowing individuals to utilize that data, arm them with that data for advocacy, but also advocacy for their self and their community. But then we're also talking about democratization of healthcare in a way in which we haven't really thought on a global scale of how we're using power to not only build power, but using that power to really drive change politically, socially, economically, for individuals. And it may be within a geographical area, or it could be in a sector. So, Bruce, I'll start with you.
Well, I think when we talk about democratizing, I agree with how important it is, and I feel as though we're really, a lot of work is going to need to go into what are we talking about. The importance of democratizing. I think that I think there certainly needs to be a better balance between how the hospital operates in the community. The voice of the community needs to be armed with the support that it needs behind it to be able to be a real participant in taking care of themselves. And I'm struck by, I've been talking this up about a little bit, and I've been amazed by how it doesn't stir up the kind of excitement that I think it should. And I think we're going to need to really be looking at the importance of this and spending a little time creating the space for dialogue about this subject and how vitally important it is to saving lives. And it speaks to the necessity of, you know, when you think of democratizing, you think not only of people having more to take care of their individual selves, but also a more of a collective approach to care that is not centered around healthcare professionals, but the recipients of care being more actively involved, and not just as individuals and taking care of their individual selves, but I see it as being more dependent on each other, recognizing how much they need each other to improve their own health. I'm struck by how we all individually make commitments to ourselves to take better care, you know, especially part of our New Year's resolution. And, you know, it's well known that, you know, a few months later, that's over. But, you know, we need a system that encourages us to form groups with each other, to be in dialogue with each other about, you know, taking better care of ourselves. You know, it's clear that, you know, when you make commitments to others to get up in the morning, to walk, or in the evening to swim, or to ride your bike, or to do whatever it is that you've decided to do, to track how you're eating, the chances of success are going to increase. And to me, that's a part of the whole democratizing process of engagement, getting people to start to see each other and the value of being working with each other around health in a different way. So that's what it brings to mind.
Francois, go ahead, jump in.
Yeah, well, you know, full disclosure, I want everybody to understand that prior to me engaging, you know, in the work with this group here, I had a head full of black hair. And then I started thinking about the challenges, and this is me today. So thank you guys. What I've been thinking about is, in fact, the use of data in our desire to democratization of, you know, healthcare. We have to start with a democratic approach to data. And part of my experience has been that every time that you use that term, the common of, you know, mortals, you know, would think that, oh, I'm gonna need to be a statistician to work with data. And there's nothing that can be more false than that. Everything is data. And it is incumbent upon myself to bring it to you in a way that is understandable, digestible, and that you can use. If I make a commitment with you that we're gonna meet once a month, at the end of a year, we should log in 12 meetings. If we don't have 12 meetings in the book, then we should start asking questions. What happened? What prevented us from meeting once a month? What can we do so that we can take, you know, corrective actions for next year? We don't need to be a statistician to understand that. So that democratization of healthcare is everybody's responsibility to translate the basics into parts that we can measure. that, I'm coming to you and I'm going to see to you that we're going to tackle this particular challenge in this community. How do we do that? Okay, I understand that. Okay, fine, let's do it, and let's check with each other within 3 months, within 6 months, within a year. Everybody can understand that, except that it seems to me that we make it so complicated that we turn people off. And when people are being turned off that way, they are not going to engage. So the challenge is on us. How do we translate this to people so that we can encourage people to then want to get involved, want to engage with us? It is really us that must take the jargon out of the whole conversation and say to people, hey, we're open, we want you, and this is what we're doing, and this is what you can do to help us. So that's as simple as that to me. The central approach to the work that I do is I would rather be wrong than be disrespectful. I want to always respect the people that I work with, their intelligence. If I'm wrong, I can correct that wrong. If I'm being disrespectful, I've lost you.
All right, so I'm sorry, we're going to have to wrap up, but I want to just talk a minute about where we're going from here, right? I think it's really important that we sort of lay the groundwork for this group, both here and those who are watching virtually, what we're talking about. Because we've been all working in a place-based sector, a place-based way, in a sector-based way. When we think about the geography in which we're working in, all the different PARs that have happened, the community health district, the community health plans that have been done by the health department, using information in the way that then people can use that information and arm them to then advocate for the things that they need. And so there are top priorities that we've already know that are really important for our community. You've already mentioned some of them around housing, our food system, maternal health, and there's some clear health outcomes that we absolutely need to address. But I think what's been missing is like, how do we take all of those things, those approaches, and we marry them with the trust that's needed, with the relationships that need to be repaired and mended, so folks understand their power in the collectiveness of our community and in partnerships, and also understanding that we have to redress a lot of the harm that has been done with individuals in our community as well, right? And owning that from institutions and organizations and bringing that all into this space. And so, yes, I do think we want to provide a space where we can have those conversations. Vital Brooklyn Initiative rolled out and it rolled on. And there were folks that were left harmed and they felt betrayed by some of the decisions that were made, and there were some things that were done. And yes, some people received some resources. But we want to sort of figure out now how we can now strategize together collectively, and what does that model look like? And so my question to you all, where do we go from here, is sort of talk about that strategy and what we want to do next. Where do we go from here after this meeting with this group, those who are watching, those who are in person with us? You want to start?
Sure. We've all been working as a team for a while now. We have a temporary name, right? We're calling the Central and East Brooklyn Health and Wealth Domain, and we don't know that that's actually we don't think that's what it will be called, but that's just, we want to get everyone's input, and we'll have a different name for it. But the idea is that especially the neighborhoods of Central and East Brooklyn where PAR has happened, and where we know what communities want more or less, and where there are One Brooklyn Health hospitals concentrated, where we have that really excellent and very potential-filled intersection of community members who are also workers in the hospital, there are just so many different opportunities for us to take all of this work that has been done with the PARs, all this work that is done to form the One Brooklyn Health Hospital, all the relationships with SUNY Downstate, with Maimonides, all of the work that came, that came together under Disrupt, and to really say, okay, like, this is the place where we're working, this is who we are. We know that there are certain things that are the priorities of the communities, and how can we narrow that down further, and how can we create action plans for working on it together, working with the community boards, working with everyone that's already here, but just really, putting in, you started off the conversation talking about, that, like, how are we gonna really get love into all of this? We have the data, we have many willing people to hook us up, connect all of us with the political power, but how can we really get to the critical mass that's gonna change all of the health and housing, premature mortality, workforce outcomes, all the things that we know we want to change. And so that's the way I would throw it out there for all of us to say a little more, and then really it's for all of us to work on in the months to come. What is this collective action that we could undertake together?
Yeah, absolutely. And so, François, I mean, we have an idea, right? There's a lot of discussions that are happening both within our group, but then folks are doing a lot of work. Some of it is coordinated, some of it is not. Folks have been here before, and so we certainly want to make sure that we're identifying who those partners are, and then there's folks who may not have been identified, and understanding that we need to call them in as well. And so, another strategy that we've talked about is a campaign. And so you want to talk a little bit more about that?
What we recognize is that there are a lot of people that have been in the healthcare sector working on the ground for a long time. However, we've been working in silos, and this is what needs to change. I need to come over to you and sit with you and learn about what you're doing, and then exchange information about what I'm doing with you also, so that I can support what you're doing, and hopefully you can support what I'm doing. But more specifically, we're also thinking about, the supply chain, that the way that we use that, and the dollars that flow into that, how we can redirect, some of that, money, and support our healthcare goals by maybe providing, investment in the community where we can create jobs, because we recognize that, health is not simply the absence of, diseases, but it is also about the housing and the education, etc. So the long game for us is whatever we are doing, if this is going to contribute to longevity of the folks living in the community, we're going to, be in there with you. If this is going to contribute to better education of our population, we are going to be in there with you. If this is going to improve the standard of living in the community, yes, we're definitely going to be in there with you, whatever shape it takes, because collectively, you can be in banking, healthcare, you can be in sports, you can be in housing. It takes all of us to come together around each particular individual to say, okay, I know we're taking care of you on the healthcare level. We're also looking at your educational needs. We know we can help with that. We can help with maybe contributing to a better job for you in the community, whatever it is, so that the individual would then in turn say, hey, I have a stake here in this community, and I'm going to put the word out to people in the next zip code to say, if you come over to this zip code, you're going to improve, enjoy your longer life, you're going to improve your education level, your access to information, crucial information, and your standard of living is going to improve. So.
Awesome. Thank you. Bruce, I don't know if any last words that you want to lift up?
Yeah, I see the democratizing as something that people are pushing for, demanding, seeing as a vital element in all of this, as a part of the vision, and very much something that has life within this whole health and wealth domain way of thinking. I also think that we're asking people to work together in ways that they haven't been working together. And I think that we have to get ourselves asking a very important question. To me, that the way I think about it, at least, is that it has to do with what will it take? You know, what changes do I have to make in terms of how I operate that would encourage you to want to work with me, to want to have trust and confidence in me. And I think some commitments have to be made that haven't been made. Some promises have to be made that haven't been made. Because everybody has to feel encouraged. And I don't think we've put enough of an emphasis on this relationship building piece and how undermined it's been, how much abuse is taken. And that has to be gotten on track. And so we have to resource that issue. Because there has to be some excitement about us coming together to be cordoning off some geographical area where we begin to all pull in the same direction on. And I think that people making these commitments is a necessary element to achieving success in all of this.
I want to thank the three of you for joining me up here. What we heard is that there's a lot that's going on, but we want to figure out a way that we coordinate it. We have a model in place that we're thinking of, but it is not fully baked. We also heard that this is impossible, but it's not so impossible that we can't do it if we pull together with partnerships and collective power, and it's a new way of working, and we have to have commitment to getting there. You want to say something?
Just one last thing. I have to recognize the fact that Maimonides Medical Center, One Brooklyn Health, and One Brooklyn Health is a network of hospitals. Maimonides Medical Center have been given some real thought to this and have been working with us consistently. They've been involving community, and a lot of what we're talking about this evening, they've been really, LaRay and the CEO, Ken at Maimonides, has been really pushing this. And it's given us a lot of way of starting to think creatively about this. And I'm very hopeful that we can get your ideas, because we don't have all the answers to this. This whole health equity stuff, this whole democratizing, where have we been doing all of this at? Is it, where is this happening in the kind of major way that we need to see it going on? I don't know of anywhere. And so we have to have an open mind, and hopefully you'll help us figure this out, because too many people are dying. And so we've got to get this right.
Thank you. Thank you both all so much. Give it up. All right, we're going to switch gears a bit, and we're going to have a couple of short presentations. Ask our team, Emmanuel, we can get the projector back. But if you have to get up, stretch your legs, if you need to take a bio break, please do so. I'm sure those who are with us virtually are already doing it, and so I don't have to give them permission. So I want to just make sure that folks feel free to move about the room. All right, so yeah, it's fine. We'll do the music. Yeah, go ahead. Stretch your legs. So we're back. Welcome back. Welcome back. Hope you got a chance to just stretch your legs for a bit. We're going to move right into our presentations. And so I would like to introduce our next speaker, Dr. Tom Lee. Dr. Lee is the Chief Medical Officer at Ganey. Dr. Lee is trained in internal medicine and cardiology, professor of medicine and public health, has performed research leading to over 300 articles in peer-reviewed journals and 4 books. And at Ganey, Dr. Lee is dedicated to cultivating a culture of respect within organizations and enhancing access to quality health care for all patients. Dr. Lee.
Thanks very much. Now, I'm not going to be giving you a pep talk or doing something. It's not a sales pitch for Ganey things. This is really about something that I think is necessary but not sufficient to the goals that were the focus of the first panel. And I'm going to show you a lot of data, frankly, and these are data that are about respect. And I think what the data show is that you can have care which people, patients in particular, consider excellent if they don't feel that they were respected. And you can't have patients who feel that they were respected if you don't have a workforce that feels that it is respected. You know, where this takes you is that we need to have a culture of respect where every patient, every employee feels like they are respected. And what it means to go from that abstraction to something real is that I think that we have to start thinking of respect as like being like hand hygiene. We do it in every interaction. Now, hand hygiene was not so great that long ago, but that is where we have to go with respect, and the data are driving that. This isn't, as I said, a pep talk. You know, this is, you know, from 410,000 employees around the country. You know, this is how they, on a 1 to 5 scale, this is how they respond to the statement, "This organization treats me with respect." And it varies a lot by position. You see that senior managers, people like me, and physicians, people like me, we tend to feel pretty good about being treated with respect. If you go down to the bottom, you see that nurses are at the very bottom. Security guards, technicians, maintenance workers, you know, they are, you know, they're in a world different in terms than from people at the very top. You won't be surprised to know that when you segment these data by race and ethnicity and by gender, basically people who are Caucasian, people who are male are always giving a higher answer than people who are not. It's just what you would expect from the data. Does it matter? Well, it really matters a lot. Like when you segment employees based upon, and this is including clinicians and doctors and nurses and so on, how they answer that statement of, does the organization treat you with respect? And favorable would be a 4 or 5, and neutral is a 3, and unfavorable is a 1, 2. And then you look at how engaged those employees are, like how proud they are of their organization. You know, we actually have 6 different statements that we use to measure engagement, but it boils down to how proud they are. And I can tell you that that engagement, it correlates very strongly with whether they stay. People who are not engaged, you won't be shocked, they are much more likely to leave the organization. And this is an area where we have to hold on to everyone who's good. What you can see is that people who feel they're treated with respect, these are employees, they are virtually all either highly engaged or engaged, and people who don't feel they're treated with respect are virtually all not engaged, and you know, they're basically looking for the door. Now, it matters to, you know, patients feel it too. So that this just looks at, on the y-axis is how patients respond to like their rating, their overall rating for care, their likelihood of recommending the hospital in the second of the 2 figures. And then when you divide the hospitals into quartiles based upon how the employees answer that statement about whether they feel respected. And it's not a shock that where employees feel respected, patients feel better about their care. Now, I can tell you, we have a zillion analyses, basically, that how employees feel about whether they feel respected, it correlates with all the other things we care about. It correlates with safety culture, and safety culture correlates with events. And as I said, it correlates with workforce retention. All the dimensions of quality, these things all go together. These aren't choices, there aren't trade-offs here. We have to go for an excellent culture where people pride themselves on the care and they feel they have respect for themselves because of that, and they feel respected for their work. Now, the last of my slides just shows that, you know, this starts down the road of, well, what do we do? How do we get to a culture of respect? And you know, this just is to show you the insight that respect is reciprocal. This is like job types, and the red bar is how they rate answer. The person I report to treats me with respect. Do they feel respected, basically? And then the blue bars is they respect the person to whom they report. And what you see is they correlate. People who give respect, get respect. As I was telling some folks beforehand, I showed this to my wife, and her response was, duh. She said, and then she said, I don't know why they let men be doctors. Every woman knows this instinctively, and you need big data sets. But the truth is, even when you know it, you have to act on it. So what we have to do, and I'm sure our subsequent talks are going to start us down that road to how do we build a culture that's the culture we want, where like respect is like hand hygiene. And we don't just do it when we feel like it. We do it for every single interaction. Thanks very much.
Thank you, Dr. Lee. And that is a good reminder of why we're here. This is Health Equity in Action. The focus of our meeting today is community and care. And so Dr. Lee just kicked off our second panel. Our first panel was on democratizing health. Our second panel is on patient tools driving health equity. And so we're going to be really exploring a little bit more the type of tools that are in use, that are being developed, that can help improve patient experience, that can help address discrimination, bias, and ultimately what we want is to improve overall health. And so with that, my next speaker that I want to call to the stage is Kimberly Seals-Alders. Kimberly is the founder and executive director of Narrative Nation, Inc. Kimberly is an award-winning journalist, 5-time author, international speaker, strategist, and an advocate for perinatal and infant health. Kimberly is a former senior editor at Essence and a writer at Fortune magazine, and is a leading voice on the racial and social cultural complexities of birth, lactation, and parenthood. Kimberly?
What a powerful conversation. Thank you so much, Dr. Easterling, for including me. I am here to lift up the voices of my community because we will not get to health equity without community accountability, and we will not get to health equity without transparency. If we look at all the great things that have been happening, these are two key factors that continue to be remiss. And so in our work at my nonprofit, we are here to center the voices of Black and brown birthing people as a critical tool for change, right? And that we need to be listening and learning and actually being held accountable. And that if we're thinking about, particularly around my focus area around maternal and infant care, we know that people are not being treated the same way, even in the same place. Even in places that purport to have a respectful culture, even in places where they are highly rated by many, many media outlets and lists, right? But Black people are being treated differently all the time, right? And so how do we honor that and actually create tools to address it? So when we look at what we know is happening in New York City, the very high Black maternal mortality rate, where Black women continue to die at disproportionate rates to white women during pregnancy and childbirth. This is consistent with what we see going on around the country, but it is particularly bad in New York City. Our Black maternal mortality rate used to be 12 times that of white women. It is down to 8. Still unacceptable, in my opinion. I hope we can all agree, right? And so when we look at some of the things that folks are doing, anti-bias trainings, critically important tools, great first starts, but no one ever checks back in to see if that training has actually improved the patient experience of care. There's literally no data that proves that trainings work for any long period of time. And it's become, unfortunately, a tick-the-box exercise at far too many places, right? So they do the training, and they go right back to whatever they're doing. We believe that maternal mortality review boards are critical tools, but we don't think we should have to solve this problem from the grave. Why does someone have to die for us to realize that there are gaps or problems on the team? And so the question that we ask is, what if we can learn from the living? What if we could capture robust, independent patient experience data from a trusted source and use that to actually prevent deaths? This is what we're doing with the Earth app. So we created Earth, which is like the word birth, but we dropped the B for bias, so it's IRTH, right? As the first of its kind nonprofit tool designed just for Black and brown women and birthing people to find and leave reviews of their OBGYNs, birthing hospitals, and pediatricians. We are all about crowdsourcing and publicly sharing where we are getting good care and where we are not. Now, on the health system side, what we have seen is that response rates to hospital-administered surveys, whether they're HCAHPS or the wonderful folks at Ganey, the response rates from Black and brown folks are declining. And we can't talk about democracy or democratizing health without talking about the element of trust. We've seen what happens to a democracy when seeds of distrust are sown. We also know that there exists a huge trust gap within the medical community, and I call that earned distrust. It is earned. There's a reason why Black and brown folks are often distrustful of health systems, right? Not that, you know, all this kind of predates many of us here. I'm looking, yeah, predates all of us, but it's something that we really have to acknowledge. And so in any situation, in any relationship where trust has been broken, somebody's gonna have to be transparent. Everybody knows that, right, ladies? Okay, so we look at the transparency as a way to repair the broken trust. When we are in the community and we ask them, why aren't you responding to those hospital surveys? They tell us they're afraid of being tracked. They don't know if anyone's going to read it. They never get any feedback on what's happening. And again, they don't know whether they're being tracked. And they have to return to these health systems to take care of themselves and their babies. And so they simply don't respond. And that leaves the health systems not having the feedback that they really need to improve. And we can't just simply rely on clinical outcomes. Just because you didn't kill us or nearly kill us doesn't mean we had a good experience. And if mortality and morbidity is our only bar, it's an incredibly low bar, and we are asking you to raise it, right? How do we raise the bar? How do we define by the community's feedback what makes a 5-star experience for Black and brown birthing people and make that our goal, right? That is what we seek to do. We ask very detailed questions. Earth is not a free-form commenting space. They are questions designed to generate data that have been developed over years of me working on the ground in the community. So we ask specific questions about positive practice behaviors and negative practice behaviors, because we have to get this conversation about bias or respect or disrespect out of an abstract notion and into specific behaviors, because what's disrespectful to me may not be disrespectful to my friend Allie over there, right? So how do we get to the details? What happened to you? Were your pain levels dismissed? Was it physical privacy that you felt was violated? Was it test delayed? Was it something as nuanced as lack of eye contact? What? So this is one thing that we seek to do, and then when we go to work with health systems on the back end to bring them this data, to help them improve, we're able to say, hey, we have 500 reviews. This many people said they were yelled at. This many people said their pain levels were dismissed. This many people said that they were scolded, and we take it down, right? Details, not abstract conversation. People felt disrespect. No, this is what happened. And here's a review from 2 weeks ago, because we don't have data lags when we leverage technology, and here's something from 2 years ago, right? So really helping them get into the details, because people can't change what they can't see. They can't change it if we're not willing to show it to them, right? So that's really important. So we work directly with hospitals, city and state collaboratives, other partners, really helping them use our reviews. We turn it into data. We turn it into actionable strategies. We help them develop implementation plans, and we hold them accountable, because our reviews are public and they belong to the community first, right? This is how we drive community accountability. This is how we drive transparency. This is our path to health equity, right? So we work closely with hospitals. We take them through an 18-month pilot. That includes review collection. We go into the community. We get the reviews. We activate birth workers as ambassadors. We pay them to support us. We generate the data. We analyze that data. We help develop strategic plans. We ask the hospital partners to implement. We go through a process, right, of constantly checking back in. You say you've done some work. That's great news. We're going to go back into the community, and we're going to see if those reviews have improved. Community accountability always. Have to honor those patient voices. We're excited to be working here in New York City with a city collaborative of birthing hospitals. We're excited about the ways that we're partnering with hospitals. And we're excited about our strategy to work with payers as well, because we know in our system, we're just highly commercialized. When payers start to say, we're looking at your IRF reviews, when payers start to say, we expect you to have a decent percentage of feedback from the communities that you serve, then we are winning the game, right? That is our next move. So right now, we're excited about the ways that we are working in New York City with One Brooklyn Health. So we're really proud for One Brooklyn Health to become our first New York City hospital pilot, in addition to the work we do with the health department. We are honored to be working with Temple University Hospital in Philadelphia. We have a pilot in Detroit. We're about to start a 3-year project in California, 2 hospitals in LA, 2 in the Bay Area, 1 in Sacramento. We're working with hospitals. We're activated in Atlanta. We are all over the country leading a mission that says that we have to be accountable to the communities that we serve, and that our community deserves the ability to inform and protect each other, to share publicly. This is a great place. This is not so much, right? We've seen what the power of reviews and ratings have done to other industries. The reality is we cannot fool ourselves. Our healthcare system in our country is a highly commercialized system. My community is not the victim of the Black maternal mortality crisis. My community is powerful. They are powerful consumers that we can use as change agents in this movement for health equity. So we're excited about our part that we're playing in doing that. We'd love to hear from you. I'm excited to be a part of this panel. Please learn more about Earth at earthapp.com. But let's remember that our voices collectively can actually generate that data, right, that's really needed and be a tool for change. Thank you.
Awesome, awesome. Thank you, Kimberly. And she was also asking for the second hospital or health system to sign up. So that was the other ask as well. So, okay, so let's move along. I want to bring up my colleagues, Dr. Gwendolyn Lewis. Dr. Lewis is the Vice President of Ambulatory Care and Clinical Services at One Brooklyn Health. Dr. Lewis has provided dignified, equitable care in a variety of settings, including intensive care, rehab, and managed care, held numerous leadership positions over her career in nursing, including Director of Nursing Education and Chief Nursing Officer for Interfaith Medical Center at OBH. And Dr. Montgomery Douglas. Dr. Douglas is the Professor and Chair, Department of Family and Community Medicine at SUNY Downstate Health Science University. Has been committed to advancing health equity and caring for underserved and inner city populations throughout his career. Family doc, community health teacher, researcher in neighborhoods and organizations across the country. With that, Dr. Lewis and Dr. Douglas.
Want to put up our slides? Okay, so we'll tell you about a tool that we developed over the last 3 years between One Brooklyn, SUNY Downstate, and Ashe Institute for Urban Health. You want to start?
Sure. And first, I just want to acknowledge those members of the research team that are in the audience. Dr. Tenye Blackwell, could you just wave your hand? And Dr. Blackwell represents Arthur Ashe Institute. Nicole François from One Brooklyn Health. And some of our other team members were here but left, and that's Dr. Marilyn Frazier.
Kiki's over there too.
Oh, yes, Kiki. Yes. Wave your hand. Kiki from SUNY Downstate. And I am the co-PI for this project along with Dr. Douglas. As everyone knows, the Joint Commission decided in January 2023 to develop and implement health equity standards. So with that in mind, we decided that we would look to develop a tool that would help us to identify health equity issues within our institutions.
So this is the team that I'll show you on the next slide. But basically, just to connect what we are talking about with what was said before, we talked about their lower rates of patient experience in the disenfranchised is much lower than in other communities. But for many years, we didn't know why, you know? So this tool was developed to try to figure out, well, maybe ask the community themselves, what really is the issue? What's really going on, This was right after George Floyd and that all those protests. And we used, you heard about PAR, CPAR, Community Participatory Action Research, right? So we asked the community itself, the patients, members of the community, and the clinicians, administrators, the medical students even. What is it that you think people should really be asking about patient experience that is not being asked? And so that's where the whole thing started. Had a bunch of key informant interviews and focus groups. That's where it started. So this is the group. You see those from SUNY Downstate. You see those from One Brooklyn and also from after Ashe. And this was the board of BKHI. But we also had research staff that we got a grant from the New York Health Foundation. And I wanted to shout out to Ali Forti, who's here from New York Health Foundation. And we also got supplemental funding from Health First, and I see more Health First guys over there as well, because they're all about how can we improve equity, right? So, next slide. Gwen.
Okay, these were the goals that we developed around this research project. And the first was to develop a health system metric that quantifies how systems are achieving health equity. The next, elevate patient and community voices to help foster systemic change. And the last, to reverse the history of systemic marginalization, implicit and explicit bias in healthcare settings. Next slide, please.
So you can see that these are all themes we've spoken about tonight, right? Talk about democratization of health. You need the community voices. And we know that the community advisory boards have been part of hospitals for many years. So we're not saying there's no community voice. What we're saying is that, do they really have a voice? Or is it who is the loudest voice that gets to speak? And do they have the data? We talked about data, right? Do they really have data on what people are feeling as they go through our healthcare systems? As you go through a healthcare system, you're going to get a survey, right? A HCAP survey. Do you know that it has nothing in it about discrimination? Yet, if you're black and brown, chances are you're going to have that on your mind. So you're going through all the healthcare systems here in this country, but there's no mention of discrimination whatsoever. So you see that we're missing a big piece. We're trying to understand why people are not responding as much, why we have a less than 10% response rate for the disenfranchised when it comes to patient experience. So this is why we did this. Go ahead.
Can I just add, my definition of democratizing healthcare is data. What's the data that people need to improve their health? So my thing is, at One Brooklyn Health, we're pushing my chart enrollment, because if you know how you're faring health-wise, you're more apt to make a change. The other thing is helping people to improve the way they self-care. And I'm proud to say that because of partnerships with Health First, partnerships during the district period, we were able to develop self-care management programs. Russell is sitting in the back from Health First. He is the one who introduced us to the Stanford University model of disease management. So now we offer chronic disease management programs and diabetes self-care management programs. That, to me, is putting that notion into action. We have to have a common definition of what democratizing healthcare is. And action without anything else is nothing. I mean, no action and just words is no action at all. So with the BKHI tool, we can take it one step further. And that is to see if what we provide as a patient experience is sufficient for that patient. to improve their health care. And as I think it was Bruce who said, everything is about relationships. And when we give relationship-based care, we're going to get the trust between providers and patients that we deserve to move their health forward. So the BKHI tool objectives were to design a new tool that would measure patient experience around health equity issues. And we would later on hope to institutionalize the use of this tool, like at One Brooklyn Health using Cypher Health, to distribute this tool and make sure that we have a uniform process in getting that data back. And then creating a means of integrating this into our common and everyday life and work at the institutions that we work for. Next slide.
And here's a key thing about One Brooklyn. They have patient advisory councils where leadership and patients, patient advisory council, where they get to, so not because of this did they start this. This is something they've had for some time. So what we're doing is bringing this data into the room of how patients really feel, and that is now discussed with leadership in the room, so that those problems or strengths, which is what we found, can be addressed in the way they've been addressed all along. It's just that we didn't have the data in the room. That's basically what's different about this.
Okay.
Yes, I'll mention that. So we mentioned in phase one. Phase one was just to do the CBPR, right? And we ended up getting information from 62 different people. So that was phase one, and that took more than a year actually, longer than we expected, because there was a lot more enthusiasm about this than we had realized. Actually, we promised Ali and the New York Health Foundation will do 4 focus groups and 10 key informant interviews. We ended up with 10 focus groups and 17 key informant because everybody wanted to be interviewed. Obviously, I can't mention their name, but that's to tell you, the level of excitement people had about this, because suddenly they're getting a chance to express what is it should really be asked. Because remember, see, we have a paternalistic system. We decide what is best to measure, and that's what we're measuring in HCAP. This is different. You're asking the community what is best to measure. The clinicians, the medical students, the lowest on the totem pole, supposedly, they are the people in the room that are hearing what's really going on with patients. And they are the ones that are telling us what we should be asking. And in phase 2, we actually got to pilot test it at One Brooklyn. And as Dr. Lewis was saying, we actually partnered with a digital company called Cypher. So basically, once patients have the experience, like in the emergency room or labor and delivery or inpatient or ambulatory, within one day, they get a text and they give the answers to the 10 questions. And that's it, very quick. It takes them less than 5 minutes, 10 minutes to answer the questions. So the answers are right there, and they come right in, and it's tallied automatically by the same people that do the same digital company, actually. And I'm sure Press Ganey could do that too. And then phase 3 is when we actually got to deploy on 1,325 patients at One Brooklyn, and actually got to see the strengths and weaknesses, actually. So it could actually be right now actually addressed. Lift up, as Torian says, lift up the strengths and work with the weaknesses. That's something that you could literally just plug and play at this point. Next slide.
So the next couple of slides just gives you an example of some of the themes that were derived from this qualitative study. Themes around trust, themes around disrespect, discrimination. So this one, for example, one patient stated, he said, referring to the doctor, "You're fat, you're overweight. I also have COPD and asthma, and I'm a diabetic. When you take a lot of steroids, you gain weight. So they fix one problem, but some medications cause other problems, right? So when I go to doctors, they tell me, oh, you're just fat. Have you ever thought about getting surgery? What? So just some of the things that we don't think about when we're giving care to patients. What else is going on with you that might contribute to the problems that we're seeing right now? And that came out when we did this survey. Next slide, please. Around social determinants of health, there were comments about the fact that they didn't think that there were ample resources available to patients to meet their needs. So this one quotes a patient saying, I was saying that the med school does try to encourage education to help us understand the social determinants of health. But I think there are, thank you very much, where we are kind of, where we can help, kind of help patients.
Reach that next step.
Thank you, this is a participatory order. Next, can somebody read the next one?
Yes.
Let's finish. So where we can kind of help patients reach that next step, so you know, you might tell them, here's a diet that you have to follow for diabetes or blood pressure. But then you can't actually help them go one step further and realize that maybe they don't have access to those particular food items that they need, or they won't be able to get the medications that they need because the pharmacy is too far. So we might be educated about what we're not, about it, but we're not given enough tools to bridge that final gap to make sure that we can actually help remedy the problem or make it a little better. And that was a medical student.
Right. So you see that we're using sophisticated research methods to integrate what the medical students say, what the clinicians say, what the patients say, what people in the community that were recruited by Ashe say, and then coded all that. They came up with like 150 codes, and then boiled that down into the 10 questions. That's what we're really talking about.
And this shows us where our gaps are, where our gaps in education are, where our gaps in care delivery lie. You order insulin for a patient, but the patient is homeless and has no refrigerator to store that insulin. So we have to look at how we make decisions about patient care in the hospital, but also post-discharge. Next slide. Okay, trust, and that is what we just discussed. Our last speaker talked about trust and the issues that it causes with patient care. Many patients don't have poor outcomes because they don't trust the providers that they see, right? Or as we know, for instance, at One Brooklyn Health, our sickle cell population tells us that they're reluctant to seek care because they don't trust that they're going to get care when they go to the emergency room or to the hospital. So they stay home as long as they can until the pain is excruciating, and then it takes longer to treat and give them some relief. So trust is a big thing. And this, I'll just read one of the quotes. It says, well, I don't trust doctors at all, just for the main fact that when my daughter was 10 years old, we were sent to see a specialist. They said they thought she had a hernia. The doctor came in the room. He didn't even examine my daughter. He just gave us a date for the surgery. And I was like, you didn't even examine her, or how are you going to be sure that it is a hernia? And today we see that with our patients. They say, patient, they're never touched. No one listened to my lungs. No one listened to my heart. And so how can you write in a chart, lungs clear? No abnormal heart sounds, heart rate normal, sinus rhythm, or something like that. So you're may be missing issues with patients that would impact on their health outcomes. Next slide, please.
Now you notice that just in the trust area, there's like 5 bullets. And you're wondering how that is going to end up. Because each of these have to be coded. And then all of that ends up in some way or form in those 10 questions. So it's not an easy thing to do, but it did take a while, but we feel that we have, and I'm sorry I cannot share that we cannot share that with you because we're working through the copyright right now, but in the next couple of months we should be able to get that copyrighted and then licensed. Because it's not just for hospitals to measure the degree of equity that they are treating their patients with, but it's also a tool to use to improve equity using patient experience as the driver. Because you can imagine if you feel good about how you were treated, suddenly you get patient engagement. Suddenly you can use that to drive how well you take care of your chronic disease, for example. Next slide. Thank you.
All right, I'm going to call up Dr. Lee and also Kimberly to come up, take a seat. We're going to do a couple of questions for our speakers. And then we'll invite the audience if there are any questions that you may have. But we're just going to take out the projector. We're done with the projector. But while they're doing that, we'll just go ahead and move along. We'll deal with it. But I want to start with you, Dr. Lee, and thank you for opening up and talking about a culture of trust. And I want to relate it to something that I've heard Kimberly talk about. That when we think about the healthcare system, and something that she talked about was some of the data, that there is no real sense of culture of safety for Black people when we're talking about our healthcare system. And so can you talk about the work that Press Ganey is doing to drive transformation, driving transformation and seeking to achieve equity? And I know that there's work that Press Ganey is leading on.
Yeah. Well, first, I want to say thanks so much for letting me come, because I got to say, I learned so much from these talks. I mean, was this all set up to get me to listen to what?
Yes, absolutely.
Yes, it was a good setup, because it just shows that, we all have blind spots, and even though we feel like we're doing a good job and stuff, having these blind spots pointed out to us is hugely important. And I think that one thing that I think people from the business world have known is that you have to segment your market, that one size doesn't fit all. In fact, one size usually doesn't fit anyone. And so that it makes the work more complicated. But getting down, understanding that these different response rates in different groups are critically important, and you just can't ignore those differences, and that you actually have to start getting the root causes for those differences in response rates, and then you have to do different things to get information and respond to it. I've worked a lot with this guy at Harvard Business School, Michael Porter, and the thing he's always saying is, what is the right unit of analysis? And the right unit of analysis is not everyone, it's not the hospital, it's different segments, it's OB and so on. So segmenting and getting down to the units where we can actually do something, is one very important thing. I think another is the importance of transparency. You can't have trust if there isn't transparency. Even if you've got good intentions, if other people don't know you've got good intentions, you're not going to get it. So I would say that we are doing a lot of specific work. We have a whole equity initiative and so on, and and some of you are working with it already. But we have a lot to learn, and I have to say this has been a very valuable night for me, and I know it'll be part of an ongoing learning process.
Thank you. Thank you. I think that that's transformative in of itself, because when leaders are recognizing sort of their own limitations, when we talk about what we don't know, and our willingness and openness to then sort of explore different strategies. And I think that's what we want to be able to leave with and then sort of pick this up, because the work is going to continue. So thank you so much for those remarks. So Kimberly, just to pick up on that, and really want to hear of what you're learning from community. What are members saying about the Earth app and how it's helping to drive change within systems? What are you all learning within your team as you're rolling out the Earth app as well in communities across the country? Because we want to bring that patient voice into this room as well.
So yeah, I mean, we think of, Earth is a dual market tool. So we have the front-end functionality, which is the rating and review platform that our community benefits from. So when we're in the community is actually so excited to have a tool like this. Again, we've come to use ratings and reviews in many areas of our life. I don't know how many of you all are going to 2-star hotels on purpose, probably not. This is part of our culture, right? And this is part of an expectation, and our ability to be able to inform and protect each other is critically important. Folks come into Earth to search all the time, right? They want to know what other people are saying about the hospitals that they're thinking about giving birth at. We know that our users and our community members are using Earth to learn, right? They search a hospital that they're going to be going to. They're going to see what went well. Did that person have a doula? What did the doula say? We accept reviews from doulas. We have a special icon for our users to find doula reviews because we want them to know what the doulas are saying, because the doula has been there an exponential number of times to the birthing person, right? And so they're using all these tools to better inform themselves. Many times they may not have the option to go someplace else, right? We get that. But at least they can better prepare themselves for the experience, or if they can, maybe, we've seen users who decide to get a doula after seeing some of the experiences folks are having. Many times people write, I wish I had a doula, and so these are all learning cues and tools. And then on the back end, when we turn those reviews into data, we're working with hospitals, in our birthing track, we ask specifically about doctors, nurses, and lactation consultants, the 3 key birth professionals that someone deals with. And it's been really interesting, like in our data, there's a higher correlation between that nursing experience than actually the doctor experience. And I think providers get, take a lot of heat, but we see a very high correlation. When someone has a negative experience with those nurses, it's an overall negative experience at a higher rate than the correlation between doctors and that doctor experience. And so we spend a lot of time working with nurses, actually, and really helping folks to understand that. I think this speaks very deeply to what you were sharing around that, that burden and folks not feeling respected, and that just gets cascaded down. And unfortunately, Black and brown folks are disproportionately carrying that burden of folks who are feeling stressed out by the system and all the other things, right? And so those are some of the things that we see. People name names in Earth, and quite frankly, I'm here for it. And we've had in our hospital pilots places where providers were named in frequency, and that means HR needs to come to the table. Should this person be getting a raise or a promotion if they're repeatedly being mentioned in our platform as a person who's disrespectful? Exactly. Let's have that part, as they say. So again, really bringing this accountability. And what we have found is that it is the transparency that holds them accountable. It's human nature. You can look at all the psychological studies. But when we hold hospitals accountable, when we hold providers publicly accountable, that provider does not want any more bad reviews coming into our platform. They do not. And they are incentivized to gather themselves, get it together, whatever needs to be done, because they know that we are going back and we're getting additional reviews. The last thing I will say is that our presence in and of itself is transformative. We recently just landed on the ground in our Bay Area project. We don't have a hospital partner in the Bay Area, which is actually by design. My ideal project is when we go into the community first, we do the review collection. The community is going to tell us what hospitals need the work, and then we go get them, invite them into an opportunity. And so just them knowing that we are present, the emails and phone calls that we're getting from hospitals, because they just know that Earth is on the ground, we're activated, we're hiring Earth ambassadors, we're giving money to birth workers to help them attend events in their community, talk to local churches in their community. This is our process, and in and of itself, the presence of transparency and community accountability is driving behaviors. And this is what we have to acknowledge has been missing. Nobody is asking folks to be accountable to Black and brown people, and it's incredibly problematic, right? And we have to acknowledge that this other way of thinking of accountability and thinking about data has not moved the needle. We are still dying way too much. So that's what we're learning and seeing, and we're excited about more hospital partners in New York City, and also expanding our work across the country.
Awesome, awesome. Thank you. So Dr. Lewis and Dr. Douglas, I want to talk a little bit. We spent some time today talking about collective impact and collaboration. And so there have been many examples of successful collaboration. And there are challenges that folks go through as they're coming together, sort of thinking about what is the shared goal, how are you sort of thinking about some of those continuous activities that are going to move the ball down the field. But you know, there are also partners that you talked about that are not necessarily in the room. All of the different key informants, all of the focus groups that you held. And so, you know, talk to us about sort of that collaboration model and how are you continuing to build on that so going forward? Because I think that's something that we have to figure out how we continue to sustain, to keep those partnerships in place, even when, you know, say a grant is not in place, right?
Yes, very good question. And what I would say is that the relationship between the three organizations, One Brooklyn, SUNY Downstate, and Ashe, was a major driver of this particular project. However, when BKHI goes to another organization, you know, they would like to use it, I would imagine that that organization is going to it's going to play out in that organization, you know, because, I mean, people want to have, everybody's talking about improving equity. And how do we do that if we don't really know how people feel? You know, because the tools that are out there are primarily about what are the behaviors that patients noticed. But our tool is primarily asking about how people feel in the areas that are sensitive to equity, like trust, discrimination, and social determinants of health. So I do believe that as soon as it lands somewhere, you will see people work together to get this done, because it's not just about improving patient experience, it's really about improving patient outcomes.
One thing which I hope you'll find encouraging, because I think that probably some of you are thinking, oh my God, these surveys are too long already, is we just are introducing an AI-driven platform so that not everyone will have to answer all the questions. It'll take you down certain pathways depending on certain triggers and how you answer certain questions. If basically you say something's fine, then you'll skip a whole bunch of things. So I think that we are going to get to better approaches to listening to people that, you know, with the help of AI. And it's not we're going to in a year or two from now. We're going to, you know, this year, you know, the 12 months in front of us.
And Dr. Lewis, if there's anything you want to add.
I think you were asking us about how we come together and how we sustain those relationships. We went through the regular process that all groups, new group formations face. Forming, storming.
Yep, and normal.
And we stormed, right? And then we came together, right?
And normalized, yeah.
And now we're performing.
Yeah.
And getting this tool disseminated out into the healthcare community is where we want it to be, performing. No one else will have to go through that because the tool is already developed. So we have sustained, and I think we've grown as a team. I think that we are engaging in other projects as a team beyond the BKHI development. But I think that it's very important that we come to some common goals, common agreements. Respect is important, just like with health equity. There's got to be respect. And we had different talents coming together to form this team. People who research for a living, people who are just clinicians, people who were administrators, but we channeled all of the positive contributions that each member brought to this team, And as a result, a successful tool was developed. Would you agree, Doctor?
Totally.
Thank you.
Absolutely, yeah, yeah, awesome. So, you know, we're coming to that time where we're gonna have to wrap up really, really soon. And so I want to come to the audience, and if there are any questions that folks want to raise, happy to come to you and hand you the mic if there are any questions that folks have, please. Yes, Russell.
Just a quick statement.
I'll repeat it.
Panel, this is excellent. This is a wonderful conversation, very much needed now. Key again, like we all talk about, is, you know, what do we do next?
Mhm.
You know, what are we going to do about it? And we've been putting together programs as professionals for so many years, and now it's time for us to hear from the people.
Right.
Douglas mentioned, Dr. Lewis mentioned, LaRay Brown mentioned at the very beginning. Let's hear from the people. It's more about a conversation than an interrogation. It's getting information from the people so they can help us drive it. The AI, the information will be given to the AI over a period of time, but at the core of this are the people. So thank you so much, Hannah, for that.
Can I just add to, I
Please,
think
please.
that before we move to AI, we need to get that human thing down pat. That we begin to talk to people and not computers to people. People already feel disconnected to the healthcare system. And then when we put AI in this, they don't feel there's a conversation going on. And I mean between people. And I want to say, as far as actions are concerned, I think we can take a lesson from something that Ms. Brown did at One Brooklyn Health, and that's holding a town hall and inviting patients and staff so that staff could hear how patients feel about our organization and the way they deliver services. And out of that, the 2 patients that are part of ambulatory care came back and said, this is the first time we felt heard. And so that's the approach I think that we should continue down that line for a while. Developing the human relationship and connection between each other.
Yes, yes. Because of my empathy, I can give him a cough drop.
We had a presentation last night, and Dr. Torian was there and invited me to come on tonight. And I just say, it was a setup. It was a setup, but I've heard so much and reflected on some of the things that I've experienced as a woman, as a female, as a mother, and grandmother. My question is this: how and where will the intersection come in for the faith community to be a part of this initiative? We've worked in the past, but when we look at being triune beings, body, soul, and spirit, then there's got to be a place that the spiritual part is addressed. And I'm not talking about preaching and you know, all of that, but being able as a leader to walk alongside those in the congregation who are experiencing what we've learned, heard, and witnessed tonight. So that's my question.
I'll start. Yeah, now I would love to answer this question from 2 kind of spokes of our work. So on the Earth side, all of our community engagement, I mean, working with our faith-based community is, you know, priority number 3. Like, we have a 7-point community engagement strategy, and the faith-based community is being a big part of that. And so we know the connection and the value of our relationship to our spirituality and to our faith-based organizations. And so that they have been tremendous partners in pretty much every city that we work. And so that's something that is built into our plan because that's important. And then I was here talking about Earth, but Narrative Nation, I also produce a podcast where I tell joyful Black birthing stories only. right? Because of the doom and gloom narrative that's so common, I decided that we needed to shift that narrative by only telling joyful stories. And at the end of 2 seasons, this is a grant-funded podcast, we analyzed those transcripts, 33 episodes, 55 guests, and to figure out, and I asked these researchers a question. What could we learn from Black Birthing Joy? What could doctors and nurses learn from Black Birthing Joy? And we created an instructional seminar. It's 90 minutes. I debuted it at Morehouse School of Medicine, and really teaching lessons from listening to positive experiences. It's not just about learning from our death and demise and near deaths. And I say that to say, in that analysis, the importance of spirituality was very high for all these positive birthing stories, people who acknowledged that, people who were allowed to bring in some sort of spiritual element, people who relied on their faith to get them through. It was a very high percentage of all of our guests. This was important. So what you are saying is not, it's not minimal, it's not minuscule, it is significant. And our data was a high correlation to people having a positive birth experience. So this is critically important. We listen to that, and I think the more folks understand that connection and that it doesn't always look like a preaching or whatever, it's going to be really valuable for us having better experiences going forward.
I would just add that our data are also very clear. People want to be motivated by something that's beyond their job description, and sometimes it's a faith-based motivation, other times it's fuzzier, but it's very clear that job descriptions alone are not enough for us to really have excellence. And like in Europe right now, there's one thing that's just spreading very rapidly. They're calling it mango moments. Some of you may have heard about it. And it just began with a journalist who was doing a documentary about people in ICUs in Belgium, and as this one woman who had been intubated for like 3 months, was extubated, and she was talking about her experience to the reporter. The reporter said, at the end, was saying, like, is there anything I could bring for you and do for you? And she said, well, I would just love a mango. And so the next day she came back with a mango, and they got it on video. It was a TV news thing, and the patient was so moved, and it set off this whole cascade of mango moments where people are like, they're small, unplanned, spontaneous acts of kindness that are not part of the job. And it's and they've written about it, they've studied it, they found that the people who give a mango moment and identify it as such, they're happier in their job, they're less likely to leave. Basically, it's a long way of saying people everywhere are looking for something more.
All right. I think my coffee fit is done.
Is there anybody who's not in the room?
Well, unfortunately, we cannot, yeah. Because it's a webinar. But I don't know if there's any last questions that we have before we wrap up. But if not, but I do want to acknowledge those who are on the live stream and thank them again for joining us. I want to give our panelists a round of applause and thank them for all of the great work that they're doing as we wrap up. Thank you so much. You can go ahead and take your seat. But I think the really important point for us is to really think about how we take a lot of the learned lessons from each of the speakers and making sure that we integrate this into our daily work. All right, so we kept you longer than we had planned. Thank you for your patience. Again, thank you for your partnership. And once again, thank you for your power, for being in this room with us this evening. Thank you all to those who are on our live stream, on the webinar. Thank you for your participation this evening. Thank you for your power, and certainly thank you for your patience this evening as well. So as I reflect on health equity in action and think about all the things that we talk about this evening, and I want to thank Russell again for not only their partnership for this evening from Health First, but also for their presence, because it is about really thinking about how we're what's next in the action, and taking this the next step. And there's a lot of work that's already being done that you heard from both panels. Our Democratizing Health panel in our patient tools to improve patient experience and those innovative strategies. We certainly need to make sure that we're integrating that work into all of our organizations. This is not just about using these data tools in the health ecosystem, because the health ecosystem, as we talked about, isn't just about making sure that we're providing clinical care, right? It's also the social care. It's also thinking about our educational system. It's thinking about our housing system. And so there's a lot that we can learn just from what's already happening in our health ecosystem that we can then expand even broader. And so we want to think critically about who's not in this room and who are the partners that we need to continue to engage. You've heard from Bruce Richard, because what's really important is that we do want to engage our workforce. There's a lot that we've learned from the science of management and labor partners, and that folks are spending so much time, 8 hours a day together. How do we then spur that into action around civic engagement, civic action in our own communities? Many of our staff who are at One Brooklyn Health live in the communities that we've been talking about this entire evening. And we want to engage our staff to do this work as well. This isn't just about expecting our partners outside of the community to come in and help us. We have power in our own organizations. How do we get them to work with us on that? And so what I would say as we wrap up is that we need your engagement. I said this from the very beginning. We need your partnership here. And so we want you to stay engaged. We're going to be doing this again. This isn't just a one and done meeting. We really wanted to kick this off, and we want to talk to you more about the health and wealth domain. And so we want you to help us inform that model. We're going to be going to our community boards in 2024. I know that we didn't get many participants to join us today, but we know that they're with us on live stream. We want them to, we want them to be working with us in this model. And so we want you all to work with us to develop this model as well. And lastly, we want you to continue to think about what these strategies are. These strategies don't really take fold, they don't really take power until we actually put them into place. And so we need to think about how we bring them into our organizations. We need to partner with you all on that. This isn't just about sort of, again, as you heard, checking a box. We're not trying to check a box. We're really trying to think critically about how we could bring these strategies into our systems. We're happy to be working with Narrative Nation. We're glad that we're working with New York Health Foundation to develop BKHI. We're also happy to be partnering with Ganey on how we can actually expand the use of BKHI, not only at One Brooklyn Health in SUNY and University Hospital Brooklyn, but other systems as well. But we need your partnership to where do we take this next. So that's a call to action, is to stay engaged. Don't leave here and expect, all right, this was cool, the food was all right, we had the lights into action. No, the work is going to continue after this. And we want to make sure that we're going to sustain our engagement, our meetings, and our discussion. And so I look forward to all of you joining us again in the new year. I pray that everyone remains safe and you have a joyous holiday season. Thank you so much for your participation this evening. I hope that folks met someone new who they did not know in this room. Thank you to all of you who tuned in live with us. We need you to continue to stay engaged with us as well. Give yourself a round of applause for being here this evening.
And when you get the choice to sit it out or dance, I hope you dance. I hope you dance. I hope you never fear those mountains in the distance, and never settle for the path of least resistance. Living